Today we're talking about a very cool topic, one that I love to discuss because not a whole lot of people talk about the ribs and the thoracic cage. So we're going to get started with this idea of how we can understand the rule of ribs a little bit better. And we've talked about this in our principles. We've talked about it in a number of different lectures we've done. The myth and science of breathing, but I want to spend a little more time today actually talking to you about the rule of ribs. And when we talk about ribs, I think a lot of times we get a little confused about the idea of the thoracic cage and everything that sort of participates to it. So I want to do a little bit of anatomy review. Then I'm going to actually play with some ribs and sort of show we're talking about the rule of ribs. And then we're going to try doing a couple practical things with you as far as things you can do at home and things you can do with your clients and your patients, and then open it up for any kind of questions or comments or maybe experiences that you've had as far as making the ribs do some work for you. So I'm going to bring my cue and my mark over here looking at the spine. A couple things that I want to bring out in the very beginning of this is that the thoracic cage is made to be mobile. And I know we talk about the word cage, and cage a lot of time insinuates that it's rigid, right? That it's you got a 600-pound gorilla behind the cage. You definitely don't want those bars to move. But in the human body, we actually know that the thoracic cage is one of the most supple parts of the body. So if you look at it and think about it, there are 12 vertebral segments that make up the thoracic spine from T1 to T12. They all articulate. In a lot of our lectures, we talk about the facet dance, and the orientation of the facets of the thoracic spine are in the coronal plane, and therefore they have properties of flexion and extension, properties of rotation, and some properties of side bending. And so when you think about that at 12 segments, potential movement in the spine of extension, flexion, side bending, rotation, you get to understand that there's quite a bit of movement that is potentially available in the thoracic spine. We'll talk about some of the restrictions that come along with that due to a sedentary life. The next thing I want you to notice is that there are 12 ribs on each side, and that is true for both men and women. I know sometimes we do biblical references. People think that women have more ribs than men, or men have less ribs than women, but we're identical. And those 12 ribs are broken down into certain categories. So we often refer to the first 7 ribs as being the true ribs, and they get that name because 1, 2, 3, 4, 5, 6, 7 are the ribs that connect directly to the sternum or the manubrium. Then the false ribs are going to be 8, 9, and 10, 8, 9, and 10, that actually connect to the 7th cartilage into the sternum. And so they hence get the name as being a false rib, even though they're very much a rib. And then the last 2 are referred to as floating ribs, and that's going to be number 11 and number 12. And those are the smallest ribs. They don't connect to anything in front. They just float there, but they are connected with muscle and fascia and connective tissues. And they are also part of this whole connection of the thoracic to the lumbar spine. So you get the idea that these 12 ribs on each side. The ribs are very flexible. So even on your own body, if you want to, you can bend and maneuver your ribs however you like. Now, if I was looking at a femur or your humerus, we can't bend our humerus or bend our forearm or bend our femur. But the ribs are filled with elastin, and it's very much on purpose because the rib cage has to be supple and flexible. So in that suppleness, in that flexibility, again, we have 12 articulating vertebrae, and we have 24 ribs that are supple and flexible. They then connect to the sternum through this cartilage, right, the costal cartilage, that is also a rubbery material. So now you have 12 articulating ribs, vertebrae, 24 ribs that most of them connect to a floating bone called the sternum and the manubrium that are connected by this rubbery tissue called cartilage. And so I want you to start getting the idea of how mobile and agile it is. And the way I like to think about it is it's a little bit more like a woven basket. If you think of the woven basket, the basket itself is sort of soft and supple. Think of the weaving of it. And if you can think of it in that light, then what happens is you can imagine it displacing and changing shapes. And that's exactly what the thoracic cage is designed to do. So when I breathe into an anterior breath, what I expect to happen is that my ribs and my sternum and the vertebrae are all going to move to be able to allow the lungs to fill up with air in a direction of movement. If I exhale or I want to move into thoracic flexion, I can feel the lungs up in the back, thinking of it more like an accordion or that basket that is always changing shapes and changing dimensions. As these dimensions change, right, it's all about suppleness. So what happens to the person that is not supple, or the person that is rigid per se? Let's say they sit all day long and they go into a slouch position, and now they become fairly rigid in this position so that the back of the thoracic spine, the vertebrae, are open, and that openness gets gapped and becomes rigid, which means that they no longer can go into extension. They can't slide that facet down and close that into extension. So we're going to spend a little more energy now looking exactly at the relationship between the rib and the spine. I think when we understand that in the rule of ribs eventually, we get a very good idea of how breath facilitates movement and movement facilitates breath. If you think of the actual ribs, right? So we're going to look at certain parts of the rib, and we refer to this as the head of the rib, and then this is the neck of the rib. So the head is the tip, the neck is coming down, this is the shaft, and then the anterior part of the rib is what's going to articulate or connect into that rubbery cartilage and help us out with that connection to the sternum. So if we look at this slide that's up right now, the upper ribs, so looking at maybe T, I'm missing some bones here, so here we go. And I always advise people to have, there we go, so to have a lot of bones. For example, here's some of my bucket of bones that I use to be able to play with to understand the movement. So this is a thoracic vertebra, and we know that because of the long spinous process and because of the angle of the facets. So the angle of the facets are actually slanted and orientated in the coronal plane. So when we look at the relationship of a rib connecting, the head of the rib connects to the inferior portion of the vertebra above. So it's going to connect into there, and then it's going to connect into the disc in between the two vertebrae and also to the vertebra below. So you can see that here in the slide where the head of the rib is articulating with the vertebra above and articulating with the vertebra below. And more importantly is that the middle of it is attached to the disc space. So that's really important for us to understand when we start talking about rule of rib 1. So I'll repeat it. Basically, the rib head is going to articulate with both the transverse, or the vertebra above and the vertebra below, as well as the disc in between. The second part of this is you'll notice that the neck is articulating with the transverse process. That also is very important. So now, if we were looking at this rib in its relationship to the vertebra below, is that it would have a little bit of articulation with the thoracic spine vertebra below, and then it also is going to articulate with that transverse process below. So it's going to be articulating on the segment below in the transverse process. So let's play with this a little bit, this idea. So in rib 1 through 7, that relationship is actually a little bit more convex concave. That means there's a hollowing and there's a roundness, right? And the roundness is the rib, the hollowing is the transverse process of the vertebra. So when these ribs move, they're going to move in orientation of up and down. That's going to be the movement of it. And we refer to that as rotation. So in a breath pattern, that would be the sternum lifting up as we inhale and down as we exhale. So that's going to be the upper 7 have a dominance of rotation. As we go down into the lower ribs, 8, 9, 10, it's more of a flat edge. So you can see it here on the diagram. And that diagram is going to insinuate that the rib is actually opening up to the side. So if we look at that opening up to the side, that's going to be the lateral breath we talk about in Pilates, of feeling the ribs opening up to the side in the process of breathing. So let's go back again. Anterior is going to be doing, in 1 through 7, a rotation. And then lower rib cages are going to be, ribs are going to be opening out to the side laterally because of the glide and the nature of the joint. So the joints always are going to predict what that normal movement should look like. So somebody who has a rigid thoracic spine probably is not going to get good displacement, especially in the upper portion, in the anterior posterior region. Somebody with a very rigid or extended, distended lower rib cage is probably not going to get good lateral excursion in their breath. So you get the idea of where that movement's coming from. Now, as we mentioned, if I take a look at 2 successive thoracic vertebrae, what we see is that the facets come together, there's the disc space in between, and the rib now is going to be in a relation that glides and angles down inferiorly. You see how the rib is angling down and come around to the front. So probably again, as we look at the rural ribs, the most important part is going to be that connection of the neck with the transverse process of the segment below. Okay? So basically, rule of rib 1 basically says that where the disc goes in that joint is where the rib is going to go. So what that means is that as I go into extension with my spine, right? So let's do a little bit of thoracic extension. I go into extension with my spine. That means that the disc is going to move anteriorly, okay? So let's just repeat that. When the spine goes into a little bit of extension, right, then the disc is going to move anteriorly. So according to rule number 1, when you go into extension, the rib's going to move anteriorly. So let's just play with that in our own bodies. And if we go into extension, right, we're saying that the vertebra go into extension, the disc goes anterior, and so do the ribs. So the ribs are going to move anteriorly with rule number 1. Okay? In flexion movement, if I take the body into flexion, right, now what's happening is the disc is moving posteriorly. So it's going to be moving back towards the spinous processes, which would be an example of this, right? So I go into flexion, the disc is going to move back, and the rule of rib says, so does the rib. So as you go into flexion, the rib is going to glide posteriorly. It's going to go backwards this way. So let's play with that one in our own bodies. We go into flexion, and we're going to see the vertebra go into flexion, the ribs and the disc are going to move back. Okay, very important to get those rules. So in extension, ribs move forward. In flexion, ribs move posterior. But what happens in lateral flexion, right? So if I'm in lateral flexion and I take the vertebra to the side, right? So I'm going to go sideways like this, right? Here's the front. My fingers are on the back, and I go into lateral flexion. The disc is going to go to the side opposite of the flexion. So if I'm flexing to the right, the rib and the disc are going to go to the left. If I side bend to the left, the rib and the disc are going to go to the right. Okay, so that again follows rule number 1. So let's just repeat it. Flexion, ribs go back. Extension, ribs go forward. Side bending left, ribs go to the right. Side bending right, ribs go to the left. So we have that nice relationship of always moving in the opposite direction. Now the second rule ties into what's going on in the transverse joint, the costal transverse joint down here on the transverse process. And this is a little more complex rule that a lot of people have a challenge with, and that's what I was hoping to talk about and share with you today. In that lower transverse process, what it says is that when the vertebra goes into, let's say this is the lower vertebra right here that is attaching to the neck, and that vertebra goes into flexion, right? What's going to happen is that rib in flexion going here, the transverse process below is going to lift the rib up. It's like taking the accordion and closing the accordion in front. So that bottom rib has to come up, the top rib has to come down to create flexion. And that's what we're experiencing in this process with rule number 2. So rule number 2 says where the transverse process of the vertebra below goes, that's the inclination of the rib. So the rib's going to incline in the same direction as the inferior vertebra, rule number 2. Okay? So if you place your hands on top of each other and pretend these are the transverse processes, if we go into extension of the vertebrae, so we're going to take our back into extension, right? We said the ribs are going to go forward, and the lower rib is going to tilt down relative to the upper rib. So the vertebrae are doing this, and the lower rib tilts down. Okay? And whenever we talk about biomechanics, we're always talking about relative to the segment above or the segment below. So you could have something else going on in your lumbar spine. We're talking specifically about 2 vertebrae, a vertebral segment in the thoracic spine. Okay? So rule number 2 says where the transverse process goes or inclines in the lower vertebra of that segment, that's where the rib's going to go as well. Okay? So let's go into extension. We said the rib's going to tilt down. Flexion, the rib's going to tilt up. What happens in side bend? So if I side bend to the right, yeah, then what's happening is my vertebrae are tilting in this direction, also tilting to the right. So on this side, that lower rib is going to be pushing up. So on my right side, the lower rib is coming up. And on my left side, the rib is going to be angling down. Okay, let's repeat that one. So if we're here, and I tilt to a side, right, then this rib is going to be tilting down, going where it goes, and this rib is going to be tilting up because of the flexion on that side. So it's always going to be the opposite. Can we give it a try? I want you to give it a try, and I'm going to get some feedback from you on these 3 movement positions with the roll ribs. So we said in extension, roll rib 1, ribs go forward. Roll rib 2, they're going to tilt down relative to the segment above. In flexion, ribs are going to glide back with rule number 1, and they're going to tilt up relative to the segment above and below because of rule number 2. In lateral flexion to the right, the ribs are going to translate to the left. The left ribs, because they're acting like a convex surface, are going to angle down, and the ribs on the concave surface are going to lift up. Same thing, but opposite, going to the left side bending, ribs are going to move to the right. Because the convex surface side, that rib's going to tilt down, rule number 2. And because of the concave side, it's going to lift up on this one. Okay? So those are the rules number 1 and rule number 2. And now we're going to play with this a little bit with rotation. Rotation gets a little more complex because when we talk about rotation, we're actually talking about the relationship of side bending to rotation. So let me give you an example of this. Fryette's law says that when the thoracic or lumbar vertebra a segment moves into something like side bending to one direction, it's going to incur a rotation in the opposite direction. Okay, let me repeat that. If I go into left side bending, it's going to be force coupled with right rotation. If I go into left rotation, it's force coupled with right side bending. Give it a little try sitting at your desk. Rotation and side bending in opposite directions. So if I rotate right, I'm going to feel side bending opposite. If I rotate left, I'm going to feel side bending to the right. Now, the way that we play with this in the rule of ribs is theoretically in axial rotation, there is no torque on necessarily or movement of the disc, which means that the ribs are not going to displace anteriorly, posteriorly, or laterally. They're just going to be torsioned in the axial alignment, okay? And what we look at in the rule of ribs is that typically that's not true. We get a rotation, we're also going to get a side bending to the opposite direction. So we can use the rule of ribs with side bending to be able to increase the thoracic mobility and improve the segmental articulation with the ribs. So we're going to give that a try. So if I go into a left rotation, right, and it force couples with a right side bending, what I can do is I can take the rib on the convex side, the left side, send it down, lift the rib up on the concave side, and then it opens up another 15-20 degrees of rotation because I've now moved the movement or the rotation of the spine up into vertebra above that lower thoracic spine. The error in this is that most people, when they move their thoracic spine, they tend to move the whole of the entire thoracic cage, which leads to hypermobility of the lumbar, cervical, and shoulder, or at least excessive force through the lumbar, shoulder, and cervical spine. Now, this becomes very important when we're looking at pathology. Many of you have heard me say that you could very easily cheat in working on movement pathology by paying attention to ankle dorsiflexion, hip extension, and thoracic mobility. Now, today we're talking about thoracic mobility. If the thoracic cage is rigid, then the cervical spine, the shoulders, and the low back are going to work excessively, resulting in wear and tear, degeneration, and potentially pain. Traditionally, as a physical therapist or a doctor, we would immediately go after treating the low back, the shoulders, or the neck. So we're doing transverse tissue massage to the shoulder, we're doing traction on the neck, we're doing surgery on the low back, and the reality is that we missed it altogether because those symptoms were a result of poor thoracic mobility. And we're going to use these rule of ribs and this knowledge of thoracic biomechanics to restore the thoracic mobility. And we can do this at every level with our exercises. We can facilitate it with breathing education and making sure that the ribs are moving correctly. Now, to do that, sometimes we have to understand what is the false movement. And so let's play a little bit with the false movement. Many of you have heard that when you do flexion, to bring the sternum down towards the pubic bone. So I want you in your chairs just to bring the sternum down towards the pubic bone and feel the compression that happens in the low back. And then come back up. Let's apply the two rules now to flexion and see if we actually create a different sensation. So this time what I'm going to do is, because I know flexion is accompanying the thoracic spine by the ribs moving back and the lower ribs moving up, I'm going to facilitate my spine flexion with the cue of sliding the ribs back and tilting them up. So let's give it a try. Send the ribs back and tilt the ribs up, and notice now where tension, if any, is felt in the same amount, if not more, flexion in the spine. And then come back up into your neutral position. Try it again, this time doing it the incorrect way of just drawing the sternum down towards the pubic bone. Come back up. Do it from the real ribs. Slide the ribs back and tilt them up, and notice the difference between your range and the amount of compression in your low back. Now, the one that I always think is more impressive than that is the actual spine extension. So if we're thinking of going into spine extension now, we said the old way of doing it would be just lift the sternum and the breastbone up to the ceiling. So you're just going to lift everything up, and notice where you feel the compression. Typically it's going to be in the back of the neck or in the low back. Very common, right? But let's now apply rule of ribs 1 and 2. And we said rather than telling them to do extension, as they do so, we're going to send the ribs forward and tilt the lower ribs down as the sternum floats up. This time, what you're going to notice is that the movement actually came from the thoracic spine, and your lower ribs maintained connected to the lumbar spine or to the pelvis. And in doing so, you maintain axial alignment, you maintain stability of the lumbar pelvic region, and you increase the thoracic extension in the thoracic spine. So you're adding 2 or 3 more segments in the thoracic spine that are going to alleviate or decrease some of the stress that you might be feeling in your neck, lumbar, or shoulders. Now, the last 2 we're going to look at is the side bending and the rotation. So if we practice our side bending, and we're side bending to the right, and we basically just bring our rib cage down like a lazy mermaid, okay? That's the incorrect way to do it. Notice where the pressure goes in that side bend. Bringing the rib right down to the hip, bringing the body over into side bending. Now this time, think of what we're doing with the rule of ribs. If I send my ribs to the left, and I take the concave side, or vex side, and I send it down, and this side up, all of a sudden it creates a larger thoracic side bending than it would if I just collapse. So again, sending my ribs now to the right, the lower rib dropping down, and the lower rib on the left side lifting up. So I'm creating that thoracic side bending up above and expanding into that accordion of the rib cage. Okay? So we've done flexion, extension, side bending right, side bending left. Let's finish off with the last experimental one of doing rotation. So in rotation, I'm going to rotate to my right. That is force coupled with side bending to my left. I send my right ribs down because of the convexity, my left ribs up because of the concavity, and it gives me another 15-20 degrees of thoracic rotation to the right. And I can do the same thing going to the left. So I rotate to the left, I send the convex side down, concave side up, and it gives me another 15-20 degrees of access in the thoracic spine. Now, there's nothing that takes the place of us experiencing and feeling the difference between doing it with an incorrect cue or an incorrect image or sensory versus doing it correctly. And I just find that when you know how to move the ribs and you know the relationships of the biomechanics to the thoracic spine, it makes a huge difference in how we articulate our spine and how we move. So what I'd like to do now is just sort of turn the time over to you to ask me some questions that I could make some clarifications for you, because I know there's always questions on this and we get it all the time in our coursework, and I just want to be able to make it as clear as possible to you. When we have mobility of the rib cage in all planes of movement, what ends up resulting in that is that breath becomes very spontaneous in any plane of movement that we want to breathe in. So it was Blandine in Anatomy of Breath that said, complex movement requires spontaneous breath. And if the rib cage is not mobile, then having spontaneous breath becomes very restricted. So we often talk about the 3 dimensions of breath being flexion or anterior, posterior, lateral, and then superior, inferior. Well, 2 of the 3 dimensions require this roller rib or the rib mobility that we're talking about. There's a question that came in. It says, I have a few clients, this is from Tara W. It says, I have a few clients whose rib cages are stuck in inhalation. So what that often means is that, and if I understand that correctly, Tara, the rib cage is already fully open from the bottom. Now this happens quite often with things like post-pregnancy or with obesity and also with aging. So here's a good little trick. I'm going to bring the camera down so you can see a little bit lower on me. But if you think of the rib cage coming down, this is the base of the sternum, and the angle coming from the sternum into the lower ribs, that cartilage of 7, should be about 90 degrees. Right? That angle between my thumbs, about 90 degrees. So a lot of times we have people who, after having a baby and being obese, are 180 degrees. And you might ask, well, how is that relevant and what does that actually mean? Well, what happens is our body will respond to its posture. So if the posture is that rib cage is distended, or the ribs are flared, as we often refer to, or stuck in inhalation, as Tara said, really the only thing we have left to bring in air is going to be accessory movement through our neck, like a sip and puff, or like smokers breathe to lift up through the neck, or belly breathing. So you'll see a lot of times people that have had, you know, postpartum obesity or aging, that their rib cage is stuck open, that they have a very difficult time getting the ribs to come back down and get the old air out of their lungs. We often refer to this also in COPD as pink puffers. And so it's like getting those ribs to draw back down and push that old air out. So one of the things we'll be looking at here is, how do I get the rib cage to move into that sort of closing position? Since it's stuck open, we need to get it to move closed. Well, we can do that by teaching the ribs to start working on the decline. So we're going to be doing extension, sending the ribs down towards the pelvis. We're going to be doing side bending over the barrel, over a ball, over an arc, and sending that direction of the rib down. And you might even have to overpressure on the ribs. So a lot of times I'll actually place my hand on that lower rib cage, and as they exhale, overpressure and draw that rib cage down like a cone towards the spine to start engaging that. And I'll even do this particularly with my patients or clients that are obese, is put a big sheet around them and have them pulling the sheet as they're exhaling to start getting the muscles to reconnect, right? Because they've been distended, they no longer connect. You get them to reconnect and start drawing or knitting the abdominal wall back together again. And if you think about what are the muscles of exhalation, external obliques, internal obliques, rectus abdominis, you have your posterior serratus inferior, you have your quadratus that hooks onto T12, and all of those muscles together connected with the transverse abdominis around the front are going to draw that rib cage down and make it so that you can be open and closed. And remember, just the opposite is just as important. Somebody whose rib cage is closed, excuse me, somebody's rib cage who's stuck closed can have the same problem. So we saw this when we were doing the diaphragm studies and the pelvic floor studies, is that people had over-recruited their abdominal muscles so much, had such a skinny waist, that they had no longer had rib mobility going into lateral opening or anterior posterior opening. So again, they had a different type of restriction. Somebody who's already open can only move from their lumbar spine and their neck. Somebody who's closed can only move from their lumbar spine or their neck because they are not able to move through a full range of thoracic spine. Great question, Tara. Lauren T. Question is, what are your go-to imagery for the movements? And another great question. Probably the best image, and even if you could get a hold of a toy that's like this, is the idea of an accordion. I feel like the rib cage acts like an accordion, and you just change your angles or directions of the accordion based on the direction of movement. So if I'm moving into flexion extension, I'm going to open that accordion and close the accordion in the sagittal plane. I might open and close the accordion in the lateral plane if I was doing side bending like mermaid and side lift and other lateral or coronal plane activities. And then rotation also is nice to do that as well. So think of the accordion, use the ribs themselves as the image. Send your ribs to this direction. Send your ribs forward and tilt them down. Are great images to get people to start moving their thoracic spine. Len P. says, are there ways of actually measuring the movement of the ribs, i.e. how much do they actually move or should they move? Boy, I wish we had the ability to do this, Len. This is a question that we probably need to get a study looking at it. It often is more like what we refer to as the arthrokinematics or the bone rhythms. So if you're familiar with something like Eric Franklin's bone rhythms, where he talks about the idiokinesis and arthrokinematics of the hip and the pelvis, we talk about how the femur and the pelvis have to move in opposite directions to allow hip mobility. So for example, when you're squatting, the femur is going to spin posteriorly, glide anteriorly, and then externally rotate. While it's externally rotating, that means the pelvis is actually anteriorly rotating. Well, the pelvis itself doesn't anteriorly rotate. It doesn't actually move. But the neuromuscular strategy of it actually does allow that to move. So if you think of allowing the pelvis to internally rotate while the femur externally rotates, that means it's open. So another way of thinking about this, Len, is like a can or a jar. If I'm going to open the lid on the jar and the lid have to move in opposite directions. And a lot of times that's what we're talking about, minute movements of where the rib, right? So here's the rib, and that rib now is doing a little bit of rotation inside that joint, which is taking it up. And it might be moving 1 millimeter or 2 millimeters in the posterior part of the joint, back by the vertebra, but it would look like 1 centimeter of displacement in the front because it's opening like a jaw or a hinge and making that space. So again, it's a great study. We could look at it. There's not a whole lot out there. I'll tell you that in Australia right now, they're doing a ton of research. It's become very high priority looking at the subtleties of how the ribs stack and how the ribs slide and how they move. And there's some great research coming out of Queensland. I don't have the quotes on me right now, but we can definitely get some of those things out to you. But I have not seen anything yet as saying how much displacement. My gut feeling, we're probably talking like millimeters, up to 5 millimeters, 3 millimeters of movement per segment, but you multiply that by 12 segments, and you're now looking at 30, 40 degrees of increased mobility that could be coming from good thoracic mobility and rib mobility. Ayanth, good to hear from you. I appreciate your participation always in our Pilates hour. Ask, please would you mind going through your rotation rib cueing again? This is exactly what today's about. I get this question all the time because rotation is a little more challenging to understand. Let's go back to our first rule that I talked about, that was Fryet's law. So Fryet's law, looking at biomechanics in the lumbar and the thoracic spine, states that side bending, I'm going to bring these nice and close to the camera, so we're looking at the front of the vertebra, side bending and rotation happen in opposite directions. So that means if that vertebral segment is going into left side bending, it's also going into some right rotation. That force couple happens automatically at the segmental level all the time, okay? And that's provided there's movement there. So now let's take that same rule and say that when we look at the rib cueing for it, if I'm going to take my body into axial rotation, so imagine that axis around there, right? The disc is not going to displace. So the truth is, the disc is not going to have an effect on the anterior or lateral glide of the ribs in rotation. So rule number 1 does not apply to rotation. It applies to flexion, extension, and lateral flexion. Now, with rotation, rule number 2 applies because it's connected to the transverse process. So based on the vertebra above and below, when they go into rotation, 2 ribs are going to be moving in one direction, and the lower 2 ribs are going to be moving in the opposite direction. That would be the axial rotation. Now, because of Fryet's law, it says not only is it going to rotation, but it also has some side bending to the opposite direction. Okay, I'll repeat that. So we say that when the rotation happens, rule number 2 is going to push the ribs into the rotation of the transverse process they're attached to, which is always the segment below, right? So if this segment's rotating, it's going to look like the rib between them is rotating to the right, okay? Or look like the vertebra above is rotating the ribs to the left. Because of Fryet's law and the force couple, now there's a side bending to the opposite direction. And that creates the properties of rule number 1 and the properties of rule number 2 in side bending. So let's go into that rotation, go into the force couple, and side bend the opposite. So I'm rotated right, side bent left, puts me into a convex, right? So the arc is going this way. If I send these ribs on the right down towards my pelvis, and I send the ribs on the convex side up towards my heart, it creates what's called a co-contraction or stability of the lower segments, and it actually frees up rotation of the segments above. And that becomes probably one of the most powerful tools that we can use as Pilates teachers and therapists, because think of the golfers, tennis players, swimmers, volleyball players, anything with rotation should be able to facilitate that rotation in the upper thoracic. What decreases that rotation? Sedentary lifestyle, sitting at our desk. So we can do more good for them by restoring that extension and that rotation, that axial rotation, that will minimize the lumbar rotation. And remember, the lumbar spine is not really made to rotate. Let me see if I can find a couple lumbar vertebrae here. If you look at the lumbar vertebra, their facets are very, very vertical, right? And so when I put the vertebra above it in place, it only has 3 to 5 degrees of rotation before it bumps up against this facet. Where in the thoracic spine, because the facet now is angled, right, what it has, it's made to do rotation. When it does a unilateral movement, it's going to rotate. So it looks a little bit like when we do the facet dance, it's going to do this in the thoracic, and lumbar is here. It doesn't have a lot of rotation. So if you lose your mobility in the thoracic spine, the rotation then has to come from the lumbar facets, which causes damage and injuries and degeneration, or the shoulder or the neck, which are often the 3 most common injury places when we don't have thoracic rotation. Hope that helps. Liz B. question says, can you touch on shearing and avoiding it using rib cueing? This is exactly what we're talking about. So Liz's question on shear force, we want to minimize shear force, right? So shear force is where the vertebra actually slides, and this is responsible for a lot of the disc pathology that we deal with, a lot of the ligamentous and degenerative changes that we deal with, and arthritis in our back. And by the way, these are all normal degenerative changes that we see, normal because everybody has them, not normal because they're optimal, normal because this is what we do in our lifestyle. We move from 3 or 4 segments too much, and we create shear force in those segments. So your question is, if I can increase the number of rib and thoracic mobility segments that actually respond to the neuromuscular plan of moving, we can significantly reduce the amount of shear force in the lumbar spine and in other joints of the body. Let me give you an example. Years ago in 1996, we did a study where we looked at segmental mobility, and this was tying more to our second principle in Polestar, our third principle in Polestar of spine articulation. And we looked at it, and we had a machine that we actually measured the displacement between all of the spinous processes from the sacrum all the way up to T2. And we only measured forward bending and back up to neutral spine. So we looked at, I think it was 30 students that had never done Pilates and never had back injury back in 1996 at Loyola Marymount in Southern California. And we took the measures until we had a standard measure, and what we found is in all of them that the primary movement was L5, S1, L4, L5. Very little movement in the upper thoracic, and nothing that we could really measure, going back to that measurability, in the thoracic spine. We then randomly assigned those 30 to 2 groups, 15 people of a control group, 15 people that were going to be in the experimental group. So the control group just rested for 45 minutes. Came back, did the same measure, had the same results. The experimental group went away and did 45-minute reformer exercises, 5 exercises, 1 time only, first time ever. We did footwork, bridging, roll down, feet and straps, and roll down, and I think bridging or something like that. I think I said bridge already. So anyway, some mobility exercises. They came back and we had 3 significant findings. The first finding was that the total range of motion of flexion had increased significantly by like 1.5 inches. And you can say, that makes sense. You warm up the hamstrings, you warm up the spine, you're going to get more movement, and that's fine. The second one was that there was more movement in the thoracic vertebra as well as the upper lumbar. And you can use the same rationale saying, yes, we increase mobility, we'd expect to see more movement following that. But the most important finding was that L4, L5, and L5S1 decreased by 50%. Now that's what's important, is because if we can distribute the movement through our ribs and through our thoracic spine in normal rotation, normal arthrocinematic movement, right? Normal biomechanical ranges of motion, but we're doing it in 3 or 4 segments instead of 2, then we avoid the shear force that causes the problems in the affected joints, like the lumbar L4-5, L5-S1, the shoulder C4, C5, C6. Wherever we end up taking too much movement is usually where we have the problem. Instead of treating those areas, trying to stabilize them, we should be treating mobility into the areas like the thoracic spine and the ribs to minimize that shear force. A great question, great comment. Kirsten L. says, I find it easier to cue ribs 3 to 10 and get clients to be able to envision how they work, but ribs 1, 2 can be trickier. Any tips here? Well, let me tell you, rib 1 and rib 2 are a problem no matter how you slice them, except for at a barbecue. They are very tough to manipulate as a manual therapist. For me to get in there and manipulate those upper ribs can be very challenging to therapists and chiropractors alike. However, there are a couple things that I like to do. I like to come up underneath the armpits of my client and just sort of slide up as high as I can up into that sulcus, feeling the rib cage up nice and high. And I start giving little tiny cues of with my fingers, following their breath and getting them to move. And in doing so, now what's going to happen is I'm going to be looking at the movement of the collarbone. So to me, the clavicle becomes indicative of what's going on in T1 and T2. Now, granted, there's not going to be a lot of movement because the space is so narrow. It's heavily vascularized. It has a lot of fascial connections to help hold the head up on top of the neck. So it is a challenging area to get moving. But it does possess all of the same movement properties, just less. So it has its greatest mobility is going to be rotation, and then extension and flexion, and then a little bit of lateral flexion. So if you were to take those ribs apart and move them, they're going to be limited. There's not a whole lot of movement there. One of the areas that you can get to it actually is through accessory breathing. So if you really want to create a little bit of mobility there, what I would do is take the tower bar, take them into a full push through, hold their head down a little bit, and let them struggle a little bit trying to find a breath. And sometimes they'll find that, and they'll go into accessory breathing. And if they're able to exchange air, you know that they're moving that first rib to be able to create a little bit of space and a vacuum to be able to get air to come into the upper lobes of the lung. I don't do that very often. I typically trust that if I can get 3, 4, 5, 6, 7 to move, we have plenty of movement to be able to minimize the shear force in other joints. Melissa W., can you please say again what the angle of the sternum should be? Okay, it's not the angle of the sternum, but just below it. So remember we said that if you put your thumb on your xiphoid process and you lie it right on that descending cartilage of 7, that would be your angle. So you bring that angle up and you look and you say, is that angle a 90-degree angle? So it should be 90 degrees, just like a right angle. And we should be able, as a matter of fact, in the Polestar assessment tool, we used to call it the FMOM, the functional, I can never remember what it's called, that's why I had to change the name to Polestar assessment tool. But we took the idea of putting the tape measure around the waist, around the rib cage, just underneath the breast, so about T7, T6 on the sternum. And after the tidal exhalation, we do a forced inhalation and measure the expansion of that tape measure. So ideally, we should be 1.5 to 2.5 inches of expansion and movement with an inhalation, okay? And then we rest our exhalation, and from there we do a forced exhalation, narrowing the ribs down. We should be able to get to somewhere close to 1 to 1.5 inches of narrowing, right? So if you think about finding a balance in that, sort of in regards to your question, we should see from that 90-degree angle, we should see an increase of about 20, 30 degrees, and we should see a decrease of 20-30 degrees on exhalation. So inhalation increases the angle, exhalation decreases the angle. If the angle is not moving at all, that means the rib cage and diaphragm aren't really moving that much. So we really want to make sure that that angle changes. And that goes back to that discussion I said where in the pelvic floor studies, we saw a lot of people that were holding their abdominal wall so tight and they had narrowed that angle. So it looked great on a camera, but they were having incontinence problems. They could not lift their pelvic floor. Their diaphragm was not descending, and they were actually in a very dysfunctional orientation. So what we wanted to do then was to get the diaphragm to release some of the contractures in the abdominal wall, and just like you would in Qigong or yoga, we'd be doing some diaphragmatic breathing practice to really try to open up the rib cage. In Pilates, we get on the spine corrector and we can work in all angles, lay it on your stomach, on your side, on your back, to get that rib cage to start moving with breath. And then you could come back and measure again and see a month later, are they getting more displacement? Are they at 90 degrees? Are they up to 2 inches in each direction? And when you start getting 2 inches in each direction, you know that you've restored thoracic mobility, and their breath now could be spontaneous based on spontaneous movement. I have another comment from Joanna L., who says, can you talk about the intercostal muscles a bit and how this helps them relax? Find many people have tight intercostal muscles, spasms, and pain where they feel like they need them worked. This is just like any joint, right? That if we see a restriction, that it's probably going to be the myofascial tissue, whether it is a strategic block, meaning that their holding pattern is not going to allow the ribs to move independently, or there's so much tension between the ribs, or it could over time, and especially if somebody's broken ribs. Like I've broken a lot of ribs in my life from jumping off of roofs, falling out of trees, pole vaulting, gymnastics. I've probably broken ribs 7-8 times. So I'm sure that there is some scar tissue that is around the broken rib that affects the intercostal tissues, intercostal muscles. So again, it could be a neuromuscular restriction, or it could be a myofascial scar tissue restriction, which would be a structural restriction. They both could happen. And those would lead to reasons why people are not able to move their ribs or have the mobility in their rib cage. So how do we address that? Well, if it is a strategic problem, the first thing we do is we teach them to move with the roller ribs and to breathe by putting them in position release. And if it's truly strategic, then those muscles are going to relax. Okay? They're going to relax and the ribs are going to move. If it doesn't do that following the strategic instruction, you probably can be sure that there are some structural restrictions that might need some attention from things like myofascial release, some manipulation, and sometimes even I've had some patients have had to have Botox or other types of muscle relaxants put in there to be able to stop the spasm or the spasticity in the intercostal tissues, especially up high in 3, 4, T2, T3 areas where people are dealing with brachial plexus problems, that they have some real structural restrictions from old injuries or trauma. So that's a sort of a different population. But what I don't do is I don't teach movement through muscle cueing. So I'm going to facilitate that relaxation through breath and through bone movement and through external imagery much more than I ever would get in there and say, try to relax this muscle or try to contract this muscle. I'd rather see it happen by moving the bones. And again, we're getting close to the end of our time. These are great questions. I have another comment and question from Sarah P. It says, if the client is older and the ribs are distended and they look rigid, should you be extra careful? You know, ribs are the most elastic bone in the body, and that still doesn't make an excuse for us to be pushing too hard on a rib, especially if somebody who might have osteoporosis. But I will give you a little insight. You know, this is just the other night, my wife Lizette was pushing on my ribs because I was asking her to give me some relief from a plane ride that I was on, and I felt like my ribs were really tight. And I realized that her understanding of the angle of the rib, she thought the rib was in this orientation, as a horizontal rotation. So she just wanted to push straight in, which was very uncomfortable and very painful to me. And I said, what you have to remember is the rib actually is in an inferior rotation. So the pushing on the rib is down, not in. And so when you look at your cueing, your tactile cueing on the ribs, what we really want to see is, that way you don't have to push hard, you don't have to do anything, but just facilitate it so when they exhale, the ribs are drawing down, and when they inhale, the ribs float up. Exhale, they draw down. And then if you want to do a unilateral side, you could hold one side down and expand into the other side, and expand the other side and draw it down. Use the inhalation, exhalation to be able to move those ribs. You never really have to push too hard on them. And just because they look rigid and they look like they're sticking out, I don't base it necessarily on its looks. I base it on how much movement they have. So use the tape measure. See if there's movement in there. If they have 1 inch of movement in either direction, they're actually doing pretty good. If they're in that over 70 bracket and they're getting that much movement, that's fantastic. Andrea J. Does thoracic mobility precede scapular and arm mobility? What a fantastic question. I happen to have, I saw a scapula. Here we go. See, it's always good to have bones. And let me give you an idea of the scapula, because this is a really important question that Andrea brings up. First of all, the scapula is not a joint to the thoracic spine. There's no real joint on this, right? So it is floating and gliding and suspended by muscles that come out from the scapula in all directions. And the natural motion of the scapula is elevation, depression. So that'd be lifting your shoulder up and down, right? It's going to be protraction, retraction. So that's coming forward and back, right? And then it also does an upward rotation and a downward rotation. So the scapula's job is to maintain the humeral head congruent with the glenoid fossa. Now that being said, if I'm going to lift my arm up, for example, in a tennis racket swing or a volleyball strike, my scapula has to move in a very interesting direction. So this is going to be the left side. It has to be able to upwardly rotate, which it does naturally. It has to be able to retract, which it does naturally, but it also has to be able to go into extension. Now, by itself, thoracic scapula does not have its own property of extension. It relies on the thoracic spine to go into extension to be able to have its extension. And it also relies on the thoracic spine for its rotation. So in and of itself, if the thoracic spine is immobile, it can still do a little bit of upward and downward motion, but it cannot open up for the congruence of doing a strike with a tennis racket or the hand. So your point is very well taken, is that thoracic mobility is a precursor to being able to have healthy scapular humeral motion over the head especially, okay? And that, you can look at that all you want. People that have rotator cuff tears is because they don't have the ability to get thoracic extension to prepare and keep the congruency. So what happens is the head of the humerus moves too much in here, and it starts damaging things like the labrum, the tendons, pushing and pinching up against the acromion, rotator cuff injuries, etc. Let me see how we're doing our time here. We're over time. I'm going to take one more question, and that is from Catherine J. She says, can we talk about rib popping? I find this to be problems with many Pilates students. Popping, snapping, cracking, those kind of things, as long as they're not painful, are not uncommon. Let me give you a couple ideas on this, particularly in the front. I know sometimes when I arch back, I'm taking a deep breath, I'll get a little pop right here on my sternum, and that's where the rib and the cartilage of the rib sometimes will have a little pop or snap. And that could be maybe because of my old injuries. I don't have any pain. If anything, it feels pretty good and liberating to feel that popping. I've had some patients that the popping is actually very painful, and they have what's called a costochondritis, where the cartilage itself is inflamed and it's painful, and when it pops, it's even more painful. So depending on what their symptoms are, if they're acute or not, it would be the same way I would look at ankles. So, you know, people walk around, they do a squat, and their ankles are crack, 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 or their knees are cracking and popping. The first question is, does that bother you at all besides the sound? And most people will say, no, it just makes a lot of noise. As we have more congruency in our joints, we will have less popping and less snap, crackling sounds. So what I mean by that is if you can get other segments of the thoracic spine, the rib cage, to move a little bit better, there'll be less stress through the one that moves too much, which might be the one responsible for popping and cracking more than the other ribs. In and of itself, I don't see it as a problem unless it's associated with a painful mechanism. To decrease it, distribute motion, distribute force. That's our whole philosophy on mobility and Pilates. You restore movement 3-4 more segments, and you're going to decrease the symptoms of the stress going through that one area. And that ties back to that great question somebody had about shear force. So we can minimize that shear force. I hope this has been helpful to you. We covered a lot of material in a very small part of the body. And I do want to bring your attention to the fact that we have the Polestar Experience Miami coming up in January. If you go to polestarexperience.com, you can also see if we are coming to a city near you. We're going to be in London, we're going to be in LA, we're going to be in Chicago, San Francisco, we're going to be in, anything I'm missing? Oh, Italy in July. And we'd also love to come to maybe a city near you if you're interested in hosting a Polestar Experience. So that's something to look at. Also, we really appreciate you sharing. When you get these links or invitations, please hashtag them and invite your friends. We had close to 200 people attending today that were part of our Pilates hour, so I know this is a good topic. And also, if you want to suggest to us, please send us topics that you would like us to talk about in the future. We're going to continue bringing you things that we think you want to hear, but when I see a good response to something like ruler ribs or the pelvic floor, I realize there's a lot of excitement about it. If there's something else you're excited about, I'm sure there's a lot of other people that feel the same way, and we love to be involved in the Pilates Hour. And if I can't be an expert in that area or bring that content, I'll find that expert and I'll bring him here, because our goal is to share information with you. Thank you for joining me, and give us your feedback, and we'll see you on the next Pilates Hour. Have a great holiday. Merry Christmas, Happy Holiday, Happy Hanukkah from Polestar to you.